Oh, hey, Chris.
Hey Chuck, how are you?
I'm good. I'm good. I'm looking forward to today's pod.
I am too. I'm looking forward to today's pod and all the other Sunday activities. A lot of good American football on the telly today, and should be a fun day.
Are you a YouTube TV guy?
Yes, and I have noticed that I couldn't watch certain things. We're not here to, opine about the ABC slash Disney versus YouTube TV situation, but that did limit my options yesterday.
Yeah, I don't think I have enough facts to know who's in the right or wrong, but everybody's trying to grab a piece of the pie.
Yeah, highly annoying. So hopefully by the time this drops, it'll be resolved. But yeah, no, it's a nice Sunday. It's a little overcast here and a little cold in St. Louis, which limits some of the stuff you can do. But overall, it's going to be a nice, hopefully relaxing day.
Yeah, yeah, totally agree. We have a good pod planned for us.
We do have a good pod plan. We have a great listener response regarding our wide awake in clinic plans, as well as a discussion about a case that you have. And we're going to talk about an article on physician thought leadership. So excited to discuss all of those things with the group today.
Yeah, yeah. I like the kind of jumping around a little bit and gives us some structure, but gives us some latitude. So maybe let's go ahead and start with Bob Vandermark's submitted thoughts.
Yeah, so Bob Vandermark, a very good friend of the podcast. I know he's been listening for a long time. Thanks for always contributing to our program. And you were at the session in Vancouver, but you thought Chuck was so busy that you didn't come up and say hi to him. But Bob gave us a really nice email about his experience with wide awake in office surgeries. So I guess uh, Bob and his group visited Don Lalonde, the godfather of Wallant in Canada in 2014, and so far has done 6,000 cases in his practice in the office. And last year, just over 2,000 in 1 year. What do you think about that, Chuck?
So last year, 2,000 cases in two office procedure rooms. Now, I don't recall how many hand surgeons he has in his group, um, but I mean, that's awesome. And I think you're a little bit aware. So in the United States, the Center for Medicare and Medicaid Services, or CMS, sort of defines the standard of how we are paid, and there are changes coming. Um, and it seems like, barring congressional intervention, that
Congress
for
is always very quick to act on these things.
oh yes, yes. For those of you who aren't following things closely, so much is getting done in the United States congressionally.
Uh,
Um, but it seems like what's going to happen for 2026, so January 1, so 2 months away, less than 2 months away, there will be essentially a negative to procedures done in the hospital, an outpatient center, or an ASC, and a positive for procedures done in a clinic setting, which for hand surgery has the potential to make a lot of sense and may finally, at least for us, make it financially viable to do those cases in the clinic setting, which is timely for us because we're opening a new center that will, I guess, allow that to be done more easily. So it's a really interesting time, and I love there's no question it's better for the patient, it's better for the surgeon, it's better for society, it's better for medical costs to do these procedures in the simplest environment.
yeah, we had one of the articles we discussed at a recent Service Journal Club was regarding procedure room cases. This was from the University of Chicago. And one of our new partners who previously had trained in Canada uh, and had seen how procedure rooms work in Canada just is always baffled by the onerous requirements for nursing, monitoring, et cetera, in the when you do a local case in the operating room in the US.
Yeah, it's and these, a lot of us are frustrated, and I apologize if I offend anyone by saying this, but AORN, AORN, the kind of nurses leadership group, has essentially sets policy, and that includes things like what OR hat you wear and what beard cover you're required to wear, and how many nurses are required to be in the room when you're doing a local anesthetic case, and it's crazy. I mean, we are required to have three people in the OR, and someone's just sort of sitting there talking to the patient, but that's a requirement, and it's crazy. It's
You know,
crazy.
it'd be a really good. I'm sure there are a lot of people who are forced to do things in the OR still, even if you're doing it Wallant. And I don't know how many of these cases I've done and you've done over the last 4 or 5 years since we've started doing it, maybe
Not
longer.
2000.
Not 2000, but probably not terribly far. I'd like to see the number of times that the nurse who was monitoring actually did anything in terms of intervention that was documented, because I cannot recall any actual episode. And there might be a compelling paper in there for any interested resident or fellow who wanted to look that up.
I mean, it's really true. The only way to change this is to document. And, we don't even need to hook them up to monitors, but that's required.
Yeah. Yeah.
Crazy.
I would love to, I'd actually would really love to see that happen. So,
Yeah, it's a good one.
if you've always got medical students reaching out to you to look for papers and projects. You seem to be a workman looking to hammer every nail. So this is right up your alley.
You and
As
I
if you
were
need another thing to do.
Well, I want to do two things, of course, two things. I want to touch on a couple of points, and then don't let me forget because I'm old and I forget a lot. I want to circle back to that paper stuff, but Bob had a couple of interesting points. So he said he has used phentolamine a couple of times to reverse the epi, and I think that hangs over my head a little bit. I've never had to use phentolamine, and others will say they never have to use phentolamine. But as a reversal agent, we currently don't have it available. Does that concern you?
It does theoretically. I think that it might potentially be in some crash carts, but I'm not sure exactly. And they always say, well, you can always go to the nearest dentist's office, et cetera, which I mean, I guess. But yeah, the number of, I mean, have not had to reverse or even get close to, that concern. So.
Yeah. And then the other comment, last one on this topic, is the facility fee. So for those in different practice environments, ORs, ASC, outpatient centers in the United States apply a facility fee. And this is another way that bigger institutions make a little money. And the patient is required to pay that facility fee, which to my understanding varies from 50 to 150 bucks dollars. And in the clinic setting, in our situation, we cannot apply a facility fee, and that's based on insurance contracts. So someone other Bob's practice has been able to do that, which is an important feature because of the extra cost associated with doing cases in the clinic. Interesting to me.
Yeah, no, I think that would be, if you're in a smaller practice with, contracts that are specific to hand surgeons, probably it's easier to revisit that with the insurers and payers as you're looking at your contracts. But if you're in a behemoth of an institution that covers every medical specialty, I'm not sure if anybody's going to be trying to negotiate hand surgery in-office procedures among this huge practice that is our university.
That is exactly right. And then the other thing I did remember, shockingly, you introduced me to a new term just before we went live on our pod, which is productive procrastination, which I think is a great term. First of all, I don't see myself as a procrastinator, but I am doing just that with a couple of paper revisions that A, don't excite me that much, and B, I seem to have enough stuff that I can feel good about myself doing those other things, but it's still hanging over my head. It's frustrating.
Yeah, so I mean, I feel like this is my life. There's always like and it's very different than what you do with the leadership for the department. But for me, like the big things that hang over your head are like things like papers, grants, and then there's all the little things that like backfill your time. And while I don't want to work on the grant, I eventually have to, but I want to feel like I'm being productive. So, for example, I have a big NIH grant that's due on Tuesday. I have spent all of my time not working on that grant, but doing all the other things so I could feel like I'm still being productive because the grant is largely done, just needs some finishing touches. But I felt very like, I was checking everything off the to-do box, doing all the little things. I was away, and my inbox was clean, my Epic in basket was clean, but this huge grant is still looming over my head. So I finally sat down yesterday and knocked it out and got it all done. But it was not until there was nothing else left to do before the grant. It's kind
What?
of like you see like the memes online about people like adding like take a shower to their to-do list and then crossing it off so you can feel like you did something. It's
That's
kind of
ex
the academic version of that.
that's exactly right. And in my mind, I say, well, if I get these eight little things done, then I'll just focus on the big thing that's hanging over my head. But as soon as you get the eight little things done, then six more little things pop up, and you're still where you were with the big thing.
Well, then to take it to, honestly, to bring it to an actual topic that I was told about and taught about early on, it's this concept of making time for deep work. So the stuff that does require more intellectual capacity and energy, things like grants, papers, for you probably thinking about a big concept or challenge for the department, and setting aside the time for that deep work, or some people call it genius time, and not letting little things like journal reviews, random emails, kind of take that time and protecting it. So when I'm at my best, when I'm at my most disciplined, I have the protected time, and then I don't do anything that is little during that time. And the little things get done between cases, after, before, and after that time. But if you are really trying to get some of that deeper, more intellectual stuff done, you have to have the protected time. And I talk about this when I do the clinician scientist thing, but it is really important. And I'm as bad about it as protecting it as others, and sometimes I'm really good about it.
Yeah, I'm not good about it. I think it's a really important point. The only thing I would add is that know yourself as to when the best time during the actual day is for you. So if you are a strongly morning person, then blocking out early morning hours, ignore your email, get the important stuff done. I think that's critical. And I know for me, it is in the morning where I have this temptation to deal with the emails and deal with this and deal with that. But blocking out that time, incredibly important.
Yeah, so when I do my best academic work is when I block out the morning and don't have meetings and can just focus on writing and doing that kind of stuff. And then the afternoon, I'll let meetings kind of creep in. But it is critical to know when you're at your best. And sometimes it's better, like if you don't have time, just better to go to sleep and then wake up and get it done when you're fresh, or if you're a night owl, vice versa. But
Yeah.
before we move on to thank our first sponsor, I did want to point out one thing that was in Bob's email about VR technology. So there's a wide awake VR thing that was developed by a hand surgeon in Michigan, and I have tried it. I was sent a demo unit, but I found that unless you're very slick with setting it up, it takes longer to set it up than to do the case. So it might be useful for distracting patients during things like a longer wide awake, like tendon repair or tendon transfer or tenolysis. But for a carpal and trigger, maybe this is something for the nurse at the top to do, is to work on setting this up. But I could never get the nurses at the head of the bed to actually figure out how to set this up in time before I was done with the case. So it's kind of frustrating.
I love that. I think it's a teaser for the main segment of our pod because it's clearly if someone's sending you a unit, you're a thought leader. And so no one sent Chuck a unit. So you are the thought leader here, and they mailed it to you to give it a try. Unfortunately, you're not an advocate.
And Jamie, if you ever want your unit back, let me know. I'm not paying for the shipping, so if you want to come get it, you're more than welcome to.
I love that. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand.
So let me tell you about a case, not really to get into the specifics of the case, although obviously we could, but it's a case I did with a partner. I'll leave that partner nameless for, HIPAA reasons, about 2 months ago. Um, and really interesting case with a several year history of increasing elbow pain and varus deformity with posterolateral rotatory instability. When and we can talk about any of these points I make in detail. When delving a little deeper, this young adult had a fracture as a child and had healed in a little bit of varus, and it was starting to catch up with them. And it's just a really interesting situation that allowed for a complex, what required a complex elbow reconstruction um, with all the joy that comes with working with a partner, especially for me, a partner I hadn't worked that often with. It's a great way to get to know someone in a different way. And as you and I have talked about on the pod, it's really fun to be in the OR with our partners. And I think we are privileged in our situation to do it, although we do it carefully and we think about time and billing and all those important things. But there is a lot to gain from these situations.
Yeah, no, I think there's a lot to talk about in that case, particularly the clinical aspects as well as that, the component of working with partners. Curious, because this has come up recently with a partner that I work with quite a bit. Whose block time do you put the case in?
So I operate with Lindley Wall, my hand surgeon partner, regularly. And for example, last week we did, and we do it. it was a bilateral complex syndactyly. So she does one hand, I do the other hand. Whoever's patient it is, it goes in their block time. And the beautiful thing about that situation in particular is I think we feel very comfortable that I'm dictating and billing my side, she's dictating and billing her side, even though we're talking and working together. With Matt Smith, one of our sports surgeons, we do medial elbow surgery once a week, and sometimes multiple cases once a week together. You've done these cases with him as well. If it is a thrower that the primary issue or reconstruction will be the UCL, it goes in his room. If and then I do the ulnar nerve. If it's a thrower where the UCL looks okay in all likelihood, but he needs to check it out without the plan to deal with the ligament, then the nerve goes in my room. And so it's probably 75% his room, 25% my room.
Yeah, I think it's interesting that what we've run into is that one of our other partners who we work on different days, and sometimes we'll slide into each other's end of the OR when we're in clinic, et cetera. And it's just a matter of whose time we put it under, and is it more his case, my case, et cetera. And then that's always made more interesting with utilization metrics as we've lamented in past episodes.
Yes, yeah, exactly right. The interesting so anyways, you get to like we know our partners from interacting outside of medicine. We know our partners often if we're kind of with them or near them in clinic and during meetings. To really know a partner, or at least one phase of them, you have to be in the OR with them. And I have to say, this case was in part really fun because I admired how this person handled the OR, handled the fellow, was skilled in did a great job planning. All of those things were really great. Now, I guess it could have gone the other way. I don't, I think I respect all of our partners, but that part was really great for me to see.
And then, to be honest with you, that partner is probably saying, well, here I am working with the number two person in the department, the executive vice chair. I better be on my A game, but I'm sure they always are. So, tell me more about this case. So, how does one develop, how often does a varus deformity eventually lead to a, posterolateral rotatory instability? It's just not something that I've heard of coming up very often.
Yeah, in my typical situation, I am addressing varus deformity or gunstock deformity in the pediatric or young adolescent population, which, there's some complaints and there's some deformity, and maybe there's a lot of aesthetic concerns involved with that. And so it is absolutely not about the instability related to chronicity of lateral and collateral ligament stretch. This is one of the very few times that I've had to address both at the same time. And there was also a small component of medial elbow arthritis. And so, highly unusual across the board, but made for a compelling argument to do really a few things. So, number one, we did an osteotomy of the distal humerus to take the patient out of varus. And when I do that operation, um, the goal is reestablish some valgus of the elbow, but it doesn't usually happen that way. It's very hard, at least in my hands, to really give 5 to 7 degrees of elbow valgus. So I'm pretty happy with neutral.
So is this more of like a wedge, like a closing wedge, or is it kind of a straight across osteotomy, put it where you want it and backfill the graft? Like, how do you guys do this?
Yeah, and there you can find whatever justification in literature that you want. I like a dome osteotomy, and I do dome osteotomies for matalung deformity, and often those are three-dimensional domes, so medial lateral A to P as well. These are two-dimensional domes most commonly, so just allowing correction in the varus valgus plane. And I like it because there's maximum bony contact and a pretty good ability to obtain a correction. My experience has been a closing wedge osteotomy leaves a sort of a zigzag deformity and a big step off that patients don't like. So I really have liked the dome. And then, our dilemma here was in a young adult, do we put one plate on posterolaterally, which is usually my MO. In this case, we added a second, small medial plate as well. It really satisfying, and I think it's going to really be helpful for the patients. That was sort of part one of three.
See, I thought that you, Peas guy, you would have just pinned it, would have been okay.
I've done that. It does make it hard to get the patient moving and makes me a little nervous. So actually, interestingly, in peds, I usually still do a posterolateral plate these days, but I may add a pin or two for a little more strength in the early days
Mm.
before callus. And you'll like this. Of course,
I
you'll
was gonna
like
ask. I
this.
was gonna ask about it. I mean, you knew I was gonna ask.
Yeah, so we did do perform an ulnar nerve transposition because when you're going from varus to vagus, you are putting a stretch on the nerve. There were sort of vague symptoms, but no strong ulnar nerve symptoms. But it felt absolutely like the right thing to do. I would ask you, how often, and I think my guess is I do this more than you, do you approach the ulnar nerve transposition from the back?
I try to avoid that as much as possible. It's kind of like doing one of your favorite surgeries upside down. It's just it seems much harder than it has to be. In that situation, I'd probably be more compelled to do a subcutaneous transposition, although it's just because of technical ease. But yeah, I don't like doing it. But if you, sometimes you got to do what you got to do.
Yeah, I've gotten used to doing it, but you're right. I don't like doing it. I think we can do a really good job. In some ways, you worry less because you don't have to think too much about the cutaneous branches. That's the only benefit that I see. Everything else is I don't want to say harder. I mean, certainly going proximally, I would say is easier dealing with the triceps and the like. But anyways, interesting. Um, and then
And there's a
lastly.
third part of the case.
Third part of the case, we did an
Okay.
LUCL reconstruction, and the lateral ulnar collateral ligament. Um, this patient clearly had the clunk with rotation and extension, and it's nice to see us correct the clunk. The lateral side of the elbow seems to heal much more reliably than the medial. We think about Tommy John and reconstructions medially. The lateral side worries me less, and I think a reconstruction is more reliable. Although the technical aspect of the reconstruction still matters a lot. And honestly, I was more of an observer in that part of the case, and it was fun to watch the technique, and it looked really good.
Is that more of a suture anchor type technique, or is it a bone tunnel detention? How was it used in this case?
Yeah, we did a bone tunnel sort of in the proximal ulna, and then we actually ended up doing a bone tunnel and tying over our plate proximally as well. So we were able to dunk or seat the tendon graft with an internal brace for additional stability, both proximally and distally.
Wow, a lot of hardware, deep implants going in there.
Oh yeah, did not feel like a hand case.
Well, it sounds great. I guess the other question I have is, how did what were the clinical complaints of instability? Was it the standard kind of when you're trying to get up out of a chair, loading it, that kind of thing?
Yes, exactly right. And there was, some of it again, there were some subtle arthritic complaints and there was mild arthritis, but it really was the instability that led to the clinical complaints that led to, well, we can't just go in and do your LUCL because that's not going to give the whole response. So that ended up requiring the bigger surgery.
Can you give any generalities about the post-op motion plan? How long to immobilize? Do you immobilize? Soft dressings only? How do you think about that?
Yeah, the plan was going to be, or the plan was, I should say, 2 weeks of immobilization, then a posterior splint. We're going to protect in pronation. For those younger listeners, the elbow is more stable in pronation when the lateral ligaments are compromised, and so keeping the patient in pronation as they do their flexion extension elbow exercises adds a degree of protection, and so we will do that for 6 weeks while the soft tissues have a chance to heal. And then hopefully at 6 weeks, we'll see some bone healing. We'll feel more comfortable with the soft tissue healing and move forward.
Nice. Well, Chuck, I want to ask you a question.
Please.
Surgeons know Checkpoint Surgical for their monopolar nerve stimulator, Guardian. But did you know they have a bipolar nerve stimulator called Gemini?
I learn every time I work with you and on this podcast. I am now learning that with a bipolar stimulation probe, Gemini provides finely controlled stimulation even at the fascicular level and is an ideal stimulator for selective neurectomy for spasticity. Want to know more? Yes, I do. I'm going to visit checkpointsurgical.com to learn more about Gemini. Do you use Gemini?
Yeah, so I actually used it recently and was, every time we have a new trainee come on service, we have to kind of go through when you use the purple one, which is the Guardian, or the Gemini, and the blue one, which is the Guardian. And it's just, again, really unfortunate that chose Guardian and Gemini both starting with the G. So now it's just the blue one and the purple one. But the Gemini is nice when you've got like a very target-rich environment and you don't want the signal to scatter. So it's a bipolar, which is very finely controlled stimulation, even at the fascicular level. But for example, when I'm doing a transferring the ADM branch, the nerve Huber, basically transferring the ADM branch to the recurrent motor branch, stimulating the ADM branch without stimulating the rest of the ulnar nerve, either zone two proper going deep or the branches as it comes off of zone one. That can be really challenging if you're using a monopolar stimulator. So, to me, it justifies the cost because it helps move the case along, ensures that my donor is okay, and that I'm leaving my zone two ulnar nerve in otherwise great condition. So, very useful for that. And then um, it's actually just easier to not stab somebody when you're not dealing with a lead that you've got to put in the soft tissues. So, everybody feels a little bit safer.
Love that. Love that. And how I hesitate to ask this question because I know you're going to be tempted to go down a rabbit hole of 30 minutes, but is that a good transfer? The ADM to the motor branch of the median nerve?
Love that transfer. It's so close to target. That one turns on pretty quickly. So I think that is a great transfer to use in a setting of a high median nerve injury where you have very little expectation that you're actually going to get thenar function coming back through a graft or something like that. So I've liked it for that, and I have started to use it for, and again, this is hot off, not even on the presses because we can't even get it published yet, but using it for patients with severe thenar atrophy in the setting of carpal tunnel syndrome that still have some fibs and sharp waves, and using that as a supercharged reverse end-to-side transfer. Technically, it's a little more challenging, but we've seen it turn on very quickly and have some nerve studies for a handful of patients demonstrating when you stimulate the median nerve seeing the response in the thenars. So that would be coming from the carpal tunnel release itself, but then stimulating the ulnar nerve in the distal forearm and seeing the CMAP response in the median in the recurrent motor and seeing that be two or three times the amount that what comes through the median. So it's got to be coming through the nerve transfer. So that's been very interesting to see. I'm not sure if it's quite ready for prime time, but it'll be interesting to see how that evolves.
Even I can see the beauty there. That sounds really, really cool. But you're not hoping to reverse atrophy, presumably, but you're hoping to reverse further muscle loss?
It could, but I think it might actually. I don't know. We're going to see. I wouldn't expect it to reverse atrophy, but I'd like to see if you can improve the motor units that are still viable, the ones that have not atrophied and fibrosed. Maybe you can pump them up a bit more. Again, and more. It's more of we've had this conversation in hand conference. Like people over time with severe carpal tunnel syndrome have just kind of adapted or don't even realize what they've lost. So it's hard to try to not sell, but talk to a patient about doing something that could give them back more of what they didn't realize they had lost until you pointed it out to them.
Love that. You asked me a question earlier. I'm going to ask you one that's totally moving on. Sorry to do that on your nerve conversation because you got excited for the first time
You
during this whole pod.
and you open up that conversation. You open
I
up
did.
Pandora's box. You knew what you're doing.
I did. Do you go on LinkedIn?
I don't. I probably I know I should. There's so many things I know I should do. Okay. It depends. Well, I guess it depends on what the point is, and this gets to your to the article I think you've selected for us to discuss. But I don't get on LinkedIn. I used to do, Twitter before it was called X. I used to try to do those things social media wise, but it just became too much. And I think that it's a good segue into the article that you talked about because the article is about thought leadership and talks about the different ways as a physician that you can be. He says thought leadership. I'm basically an influencer, I think. And that was just not the right lane for me. But there are other lanes that I think work better. So please.
Yeah, and I want to hear. My wife and I talk about this, and my wife's in the business world. My daughter recently leveraged LinkedIn for connections as she sought her first job out of college. I think there's a lot of benefits of LinkedIn. There's also increasingly a lot of stuff that doesn't interest me, and a lot of people that sort of put themselves out there with opinions and strong opinions, and I don't like a lot of it. I do like I do like a good bit of it. And Benjamin Schwartz, who
Well, hold on
well,
before we get into that.
okay,
At its best, at its ideal, what is LinkedIn? What does LinkedIn add for you?
different ways of thinking about things, and often those things are medical, but they're not exclusively medical. And so, finance, MBA stuff, which I continue to try to stimulate myself with. Um, I don't, not political. That's not really what I
So, but you're
want.
using it as a content aggregator as opposed to an actual networking platform, which I think is it's got both functions from what I understand.
I think that's very true. Yeah, I don't use it for networking. Maybe I should. Again, it's an opportunity, and maybe it's more important for my 22-year-old daughter as she develops a network. We are fortunate to sort of have a built-in network. What you can never have too big of a network, but balancing those things is hard. And so for me, it's about education, different ways of learning, access to people that I otherwise wouldn't have access to, and honestly, thought leadership.
All right, so tell me about this article from Benjamin Schwartz.
Yeah, so again, don't know him. He's an orthopedic surgeon, I think. I'm pretty sure.
Yes.
Um, and I just follow the link because, again, he's one of the people that I think I will click on and try to learn a little bit because I have respected what he's had to say. But this article is called Thought Leadership 101, Getting Started. It actually is posted in the New England Journal of Medicine Career Center section. And he talked, the brief overview is he talks about what thought leadership is and how to do it in his personal path. And I love that kind of discussion. Um, his personal path is interesting.
Yeah, I mean, I guess defining thought leadership is, not just getting clicks and likes, et cetera, but it's actually about providing perspective from somebody who's been in the clinic, both from a actual technical, how I do things clinically, but also like what it's like to live life as a clinician, and using that perspective to inform the healthcare quote ecosystem. Because, and I think this is the same way at a lot of places, but especially in the States, there's so many things about providing healthcare that's not about actual healthcare.
That's right. And he starts off by saying, and I quote Dr. D, the first 12 years of my career were standard. See patients, do surgeries, be on. I was a quote lunch pail doctor. As my career progressed, I developed an interest, blah, 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 and other things. And then it becomes how do you further develop those interests? I've not heard the term lunch pail doctor. It's another thing I've learned today. I mean, it's a pretty good expression. Doing this super important work of taking care of patients while we're stretched or not stretched in other directions. I like that.
I will tell you that the last couple of years, as I've tried to kind of navigate the second decade of my practice, my career, how I want to do it, I can't do it the same way I did it for the first 10 years. I've tried to figure out how much I like being a lunch pail doctor quite a bit, to be honest with you. And I'm trying to, and now I'm just talking through kind of my own stuff right now, but like trying to figure out where research and leadership lies for me going forward, because I've always thought that's what I wanted to do, and I still enjoy doing those things. But it's interesting. I came back from, being away so much in October, and I really loved my first clinic back. I loved it. I just really loved being there with people and seeing post-ops and seeing interesting things and then being in the OR again. It's just the things I looked forward to the most were those two things, which is weird to think about looking forward to clinic after having a love-hate relationship with it in the past. But yeah, I realized this is what I really enjoy doing. So right now, I'm living in that era. I like being a lunch pail doctor.
As do I, as my wife reminds me constantly as I consider what's next. Giving that up would be really hard. And yes, you can magnify your influence in other leadership domains, but I get joy taking care of patients, a lot of joy, and giving that up I don't know this want to do. And I've seen others. Now you have the skill set to do whatever you want. I've seen others who are great doctors, but may not have those leadership instincts try to insert themselves in a leadership pathway. And that's the one that makes me cringe. Like, do what you're good at, which is hard to be introspective on, but certainly important.
Yeah, he talks, in this article, Dr. Schwartz talks about kind of the traditional lanes that you are an influencer in as for academics, which is, writing papers, getting up on podiums, et cetera. And I think so for so long and probably for too long, excellence in those domains of, research has been equated to perceived excellence with leadership skills. And we know that's not always the case. And I think that that's where, like you're saying, like, people assume you're good at one thing, that you're going to be good at the other parts of the next phase, leadership, et cetera. And that's not always the case. And I think that's the real challenge.
That's exactly right. There's some good takeaways for those listening who think they want to be a thought leader. And as we've talked about, there's a lot of different thought leadership lanes, whether that's working with industry and product development, whether that's administratively, whether that's purely academically, whether that's procedurally. Anyways, lots of different things. And I like some of these rules. So one of the things he says is that have a clear purpose, leverage storytelling, discuss timely topics, and support your ideas with facts and data. Those are things that I think you and I would agree upon are incredibly important. And this podcast is certainly one lane that we have chosen.
Absolutely. This is definitely a lane. And, I agree with everything that he said. And one could argue that you don't even need to have facts and data to become, a thought leader. And, putting all political things aside, you can see it's on display with the nominee for the Surgeon Generalship of the U.S. Is that, that's a person who has very much relied on a narrative and a story. And honestly, stories probably carry more weight and power than data and figures at a certain, data is not going to change people's minds. Stories will. Now, obviously, the ideal is stories backed by data, but that's not always the case. But it's finding something that resonates. The experience that I had going to the Hill to lobby, it's been a while now, but it was always stories. It's not the it's not telling about all the frustrations you have with, the percentage of prior authorizations that you have to do. It's actually telling them a story about how a patient's care got slowed down because you could not get the authorization for the test or for the procedure and how much that patient suffered and what kind of stress that caused them, et cetera. Not, X percentage of procedures needs to get authorized by insurance. This is ridiculous.
Yeah, storytelling in 2025 is important in every domain, and certainly in this domain, how we market to patients. Those stories are compelling. I'll never forget that early in my career, a child was flown across several states for whatever reason with an amputation in the distal forearm. Flew over several spots that I thought should have been able to take care of him, didn't. And, thankfully things worked out. We replanted his arm and he did relatively well. And there was a couple articles about it. And, I thought that would move on. I can't tell you the number of times that has resonated with a patient who has a carpal tunnel syndrome, right? It shouldn't, but it does. That story demonstrates something to potential patients. And obviously not the goal, but the storytelling in all our domains matters.
So I think there are a couple of other interesting points here. One of the things he talks about is, essentially authenticity, kind of staying in your lane, not opining just to opine about something you have no clue or no credibility in, and saying what he says. I guess here is saying indexing what makes you unique. Now, I think that's probably one of the hardest things for people to understand is what does make you unique? What gives you credibility to try to pursue thought leadership? How do you think about that? I mean, we kind of, I won't say we fell into this with the podcast, but because I think that we've tried to exhibit our credibility with the traditional ways too. But I think the podcast has amplified and reached new audiences in ways that we probably wouldn't have otherwise.
Yeah, the podcast is an interesting story. First of all, we didn't think it would be this long-lived, and I think the fact that we are impacting listeners and young surgeons and therapists, I think, is why we continue to do it. You and I have acknowledged being uncomfortable with some aspects of the podcast, and first of all, we don't claim to have all the answers. We don't have all the answers, and we're free to admit that. And we have opinions. We can share what's worked and not worked. But that willingness, I think it makes us more real. The willingness to say that we don't have all the answers, I think is part of why this podcast, I think, has resonated.
Yeah, no, I think it was always uncomfortable for me early on, just in practice, to admit when I don't know things, and when I needed some time to think through things. And I've become more comfortable with that. And I've talked with, more junior level people about like that's going to be hard for you when you start, not just that person in general, but just anybody in general starting off. You're going to want to feel like you have all the answers. You just came out of training, you should know everything. But you don't realize how much you don't know until you start practicing and having to be, uh, responsible for that patient's care ultimately. And I remember one of our mutual mentors, Dr. Gelberman, would always say, the buck stops here. If we don't figure it out, nobody else is going to be able to figure it out. And that's not really true, but that kind of weight is something that weighed heavily on me early on. It still does, but I'm becoming more comfortable with saying, you know what? I'm just not sure. I need some time to think about it. I need to talk about it with some other people, or I'm going to send you to somebody else who has more experience or a different perspective than I.
And that's the benefit of experience. And I've said this before, as you know, at my stage, if I say I want you to get another opinion, A, I mean it. B, I think it could be beneficial. And I don't want to falsely, and sometimes it's falsely, claim that I know the answer. That's much harder in your first year or two of practice for so many reasons, which we have talked about. So I think that does come back to this point of be authentic. And as he states, focus on quality over quantity. It's not trying to pepper the landscape with all of our thoughts. It's about, your lane and what you bring that others might not, or how you bring it that is different. I really like that.
Yeah, and it's not just about, hot takes and controversy, et cetera, because eventually people will tire of that if you're looking to build a community or a following, et cetera. And he touches on something that's really important here about, oftentimes, people will share cases, and you should never do that to try to disparage another specialty or another doctor, et cetera, because nobody's perfect. You don't want ever just to look like you're trying to dunk on somebody else because you're better than they are. And then there's a lot of patient privacy considerations, both for the individual patient and then also for your institution that really need to be considered. And to be honest with you, that is what has steered me away from doing any sort of case sharing on social media because I used to do something like that, probably 7 or 8 years ago, and I thought it was just fun and interesting. It was. And I try to do it in a tasteful way, but you never know kind of who's looking at this and how it could ultimately be super scrutinized.
Yeah, all true, all true. I don't know that I have much else to share other than again I recommend this if younger listeners or listeners of any age are thinking about how to connect and amplify their voice, have an impact aside from their clinical practice. I think these are good guidelines to consider as you move forward.
You were the original on this. You were the OG with the blog. Now blogs I think have evolved into Substacks essentially, right? Like how
Yeah.
is the Substack different than a blog? Just out of curiosity. Just it rebranded?
It's a little bit rebranded. Substack's cool. I really like it as a social media outlet. I don't, doesn't strike me as a congenital hand blog should now be a congenital hand Substack. I am on Substack more than I'm on other social media platforms. But you're right. It is sort of a replacement for a blog. It's a modern blog for most topics. Uh, Totally off topic. I'm trying to sort out how my blog sort of survives in the era of artificial intelligence
Mm-hmm.
because the artificial intelligence search is different than SEO. So it's an interesting concept and conversation, which is not for today.
Well, I think the last part that we should close with is saying here that thought leadership can be a double-edged sword, quoting the article. Be mindful of chasing engagement metrics or wandering outside the bounds of professionalism. For us, I mean, I think with the pod, we've been intentional about kind of staying in our lane and understanding what we do best. And, perhaps there are a lot of opportunities for expansion of, I know that you've talked about franchising the edutainment of the pod to other specialties. But we're still looking for somebody to take that idea, run with it, and pay Chuck royalties. But honestly, this is fun. I certainly encourage other people to look for ways to educate and to engage. Because what's a successful formula in 2020 to 2025 is certainly going to look different in the next decade.
That's right. We may be podcasting in 20 years and no one's listening to podcasts. We may be stuck in our lane right here.
We'll be stuck in our lane with our loyal group of listeners. So, first off, I will say the book that Macy and I successfully or unsuccessfully plugged in a past episode has been released and is available to purchase. I was excited. I got the physical copies in my office. And please, if you're interested, nerve transfers, rehabilitation after nerve transfers for the upper extremity. It's a Springer book. You can buy it online. You can buy it on Amazon. You can buy an ebook. Super helpful for clinics. I'm looking forward to disseminating all those amazing protocols to all the different hand therapists that we work with in our practice.
Congratulations. And yeah, really important accomplishment. And books like that still matter because they do provide, I would say, standardization and a level of comfort, which, you can figure out the technical in the OR, but the rest of it matters a lot to success.
And there's so much more to successful surgery than the actual surgery.
Yeah,
Not to belittle the surgery, but everything else matters too.
for sure. All right, this was fun. Have a
Yeah.
great day, and
All right.
look forward to the next one.
Same here.